Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat with Chidester. MD.
Well, this is, I can't believe it, this is episode number 8.
8, yep.
Number 8. So, on our last episode last week, again, this is Chit Chat with Chiddy MD and co-host Ron Nichols. We are here today again. This is episode 8. So, I can't believe it's been 8 episodes.
That's 2 months.
Yeah, 2 months.
2 months worth of episodes.
Every week. We do it every Friday. You guys get a new episode. We have new special guests. It's been awesome. We've had some fun guests on, and we're going to continue to do that. I think we're actually going to have different seasons because I have some stuff. We're going to talk about this today. I have some stuff coming up related to the boards that I'm dealing with, and so I think we'll probably end this at about maybe episode 10, and then we'll start a new season.
2 more episodes after this. Take whatever break you need, and then go into it. I guess even I kind of was thinking about this last night. You know how when like new shows come out, they have the pilot season. Pilot season is usually like an abbreviated season.
Yeah.
So this is kind of like our pilot season.
Yeah.
So we're going to do these 10 episodes, and then when we come back for the next thing, we'll, hopefully it'll turn into a whole year. We'll have 52 episodes for.
That'd be awesome.
I mean, it might not be because we'll have holidays and things in there, but if we,
close.
We can maybe film multiple times in a week, and that would be my goal, is to do 52 episodes. Straight. I think hopefully people are still wanting to listen.
Yeah. Hopefully we find interesting things to talk about.
We've been getting some consistent viewership and listenership, so it's encouraging, and hopefully we'll just get better as more people will become aware that you're divulging all your surgery secrets on here.
I don't have many secrets, but what I do have, I will share. Yeah, that's what I like about plastic surgery. It's there. I'm not saying I'm an artist, but there's a lot of plastic surgery that is not cookie cutter. So, for example, today I had a case. I did some stuff I've technically not done before, meaning I haven't had to do that because
in the field, like would you have done it as part of like your training, like in school or whatnot, or
I've done similar things, but not not to what I had, because this patient had a problem that I've never encountered, or that's very rare, and so. This is what I like about plastic surgery, is that it's the one, orthopedic surgery. You think about orthopedic surgeon, what do you think of? Bones. Okay, if you had to pick one organ.
I'm glad you didn't wait for me to answer that, because
what we just said, hammers?
No, I don't know when it comes to
Chainsaws.
all the technical fields in medical. I don't know any of them. Like pediatric, I know that's kids.
Kids, perfect. Okay, so kids. So they do deal with kids.
What is the foot one?
There's podiatrists, or there's orthopedic surgeons who specialize in foot and ankle.
Right, okay.
And then there's, let's say, neurosurgeon. You think of brain, right? Brain, spinal cord,
neurosurgery, I would have known that.
Yeah. Vascular surgeons work on blood vessels, like bigger vessels, like the aorta and stuff. General surgeons, the term general surgery is, I would say it's kind of evolving, or it's not so much what it used to be. General surgeons used to do almost like everything. They do like orthopedics, ENT type stuff, but that's kind of partitioned out. And even other specialties, are kind of doing that too. So, plastic surgery, when you think plastic surgery, people think, oh, breast augmentation. Well, no.
It's immediate, that's one-to-one correlation.
Surgery, but, what's the thing that ties plastic surgeries together as a specialty? Right, and this is what we're going to talk about today. We're going to talk about what plastic surgery is. I know you have some stuff. And then I'll talk about what board certification is, and the importance of board certification in whatever type of specialty of a doctor you're seeing. We'll talk about the differences. I am not yet board certified. I'll talk about that. Why?
I'm board eligible, right?
Board eligible. So I've taken my written board exam. I've taken many exams, but I took my actual, the one that counts, written board exam for the American Board of Plastic Surgery. I passed that actually 2 years ago. And then I had to collect my cases for a 9-month period. So as soon as I finished fellowship at USC, at Orthopedic Hand.
It's almost like doing when you're getting your driver's license in school. You do a driver's test, and then you do the field test. Yeah. You pass the written test, and now you've been doing 2 years of a field test, kind of, so to speak.
Yeah, so the last 9 months in my practice. So one, I was actually practicing on my own as a, I call it attending, or my own class, as a plastic surgeon in my practice. Every case that I did, I had to log for the American Board of Plastic Surgery. So I did almost 150 cases that were considered major cases. Major cases, so like if a little kid has a cut on their brow or something, fix it. That's not a major case,
Right.
A lot of stuff they do is not even considered major cases. So these are like like legit full cases. Most cases are anesthesia. They're long cases. They're whatever. And so the American Board of Plastic Surgery, I submitted all these cases. I gave them what I did for the case, any complications that had for the case. I give them all these details, and I submitted that. Then they came back to me this past summer, and they said, okay, you did enough cases. I had to have 50 major case minimum, so I almost tripled the amount I needed, right? Some people don't get enough cases, which is crazy, unfortunate, in their practice. They just don't get enough. So I had enough cases. They selected 5 of my cases, and they said, okay, of your 100 or whatever cases, these are the 5. We want you to now put kind of a case report together on those patients. So from beginning until now, what happened? What was the presentation? Why did they come to you? What did you do for surgery? What complications did they have? How did you manage those? Did you get consent? Did you get photo consent? Did you take photos? And they're very, very, very strict on getting photos in post-op. So it's very involved, and it's very detailed, And then they want, also, I had to have 7 letters of recommendation from people I work with, nurses, anesthesia, people in the hospital, all these letters. I also had to submit every single advertisement I ever put in the last 9 months, anywhere. My Instagram page, my Facebook page, I had to send everything to them, to say that I'm not advertising that I'm board. I'm not board certified, like I said. I'm going to say that right now on this thing. Same thing. I'm not board certified yet. I'm board eligible. Well, yet is the hope, the promise. I'm eligible, meaning I'm able to sit for the boards, and I'm doing that in like 2 months.
I am honestly exhausted from listening to you list those things, let alone thinking about you having to do all that. Like, that's an insane amount of effort, which it's for the right reasons that you have to go through that, but like, just listening to that list, I can't imagine like the strain mentally, physically, like you went through to do all that. Is that a process that you will have to continue throughout your medical career, even after you're initially board certified? Knock on wood that you are board certified.
Yeah. So let's say, when I become board eligible, there's like a 8-year period when you're eligible that you can take. So let's say it didn't work out this year for whatever reason, I could do it again the following year. So I can do it several times until I kind of meet the criteria and then pass the boards. But once you're become board certified as a plastic surgeon, okay, we'll talk about other boards soon, but as a plastic surgeon, American Board of Plastic Surgery, there's a 10-year period where you are board certified, and then you have to maintain that through maintenance of certification. So there's tests you have to do, there's things you have to do. It's not the same. I have to go do oral boards again. This is what we call oral boards, meaning I'm going to have to go to Phoenix in November to talk about those 5 cases that I submitted to professionals in my field who know what they're talking about, and they're looking at my cases and they say, why did you do this? What could you have done differently? And so they kind of go through my cases and just see if the whole purpose is, am I a safe surgeon, right? Is he doing things that's like out of the scope of normality for a plastic surgeon? Okay. 2, is he safe? Does he make good decisions? And 3, is he not like trying to con people? So like they're just making sure. Again, this is for the public, right? This is for safety of the public, and this is why you see people just harping on it so much of safety and see if they're board certified.
So just to be clear, you still have to do that oral board process in November.
Yeah.
You're going to be going to Phoenix for that.
Yeah.
And is it kind of like I think back to when we were in high school and we'd have to do like oral report cards or something, right? So you're just I picture you in this big room with all these fancy people behind a desk, and they're asking you questions on the spot, and you don't get to reference notes or anything. You just have to be able to answer on the fly. Is that kind of the process?
Yeah, there's a couple parts to it. So, in terms of my cases, I need to know exactly everything about my patients, right? I need to know all that information. I need to know what type of anesthesia they had, what...
Without referring to any kind of notes, right?
Yeah, because they have my stuff. So I need to know my stuff cold. They're my patients, and so I know there's obviously details I want to make sure I know. But, yeah, and it's usually there's 2 so there's 5 cases. So each case is in a different room, and it's like with 2 interviewers.
Okay, so
it's not a big panel.
So they don't just necessarily like ask you one question about one case and immediately switch to another one. You can kind of
my understanding is
get your frame of mind of okay, I'm doing this case.
Yeah, like per room, it's like each case.
I mean, I guess I kind of just envisioned that the purpose, not the purpose of this board, but like one of their goals is to try to trip you up and say like, oh, let's ask him this question, then let's go talk about this case and see if we can get him, right?
Yeah.
But
I'll be honest, I don't think it's that way. And what I've heard, especially lately, because plastic surgery, it's a small specialty relative to a lot of other, it's a small community, and we're trying to help each other out. We're trying to be safe, right? That's the main goal, safety, but also like we're trying to promote plastic surgeons and who are safe. And so it might have used to have been that way. Quite honestly, it was very more malignant, but I think it's changed over the years, and so it's way more like there's certain goals that each of the interviewers are trying to meet. They have questions that they have to get answered, and so they'll kind of push you through the case to see, to get to, because if we just talk about one thing, then they may not actually know if I'm safe or, so they have to get through certain points. So try to be very objective.
So the board exam, you go through each of the 5 cases. Is the result of those interviews or oral exams, will that determine you're board certified, or is there another step? What does that process look like? I guess you get an email saying congratulations, you got a 90%. Like, what does that look like?
Yeah, I mean, again, I haven't done it yet, but from what I've had, so this is a process that goes back 8 years for me. This process for the American Board of Plastic Surgery, this is not you're board certified. Yeah, this takes 8 years. It's taken for me, like some other people maybe a little bit longer. Sure, I did a fellowship.
You had
so
to start
extra
planning
year.
for this 8 years
ago. Yeah, so 8 years ago, when I started as a resident, as an intern, I had to sign a paper saying that I was interested in becoming board. I was in a accredited training program for plastic surgery. So that's the first step. Is okay, are you in a program in the United States that's accredited by the ACGME that will get you the cases you need to do? Because I have to be exposed and train and do a certain breadth of cases. First, before I even can say, okay, one, you graduate plastics residency. So that's part of the requirements is, okay, you have to graduate from an accredited plastic surgery, training.
Right.
So that's the first thing. And that started 8 years ago. And so I had to collect all my cases back then. Every week I had to log every case. I did over, 3,000 cases in residency, and then over 1,200 cases during my fellowship 1 year. So it was like almost 4,500 different cases or surgeries that I did in the last, 7 years of training. And then I come out and have to do my own cases. So that's when that started. And then I had to take a test every year. It's like called an in-service exam.
Kind of like making sure you're on track.
Yeah, is he
still?
on track? Is he failing? What's going on? Yeah. Because that led up to that written exam for the American Board of Plastic Surgery that I took
A couple months
after I graduated.
Oh,
No, I took
2
that
years
after I
ago.
graduated. So I had to do that while I was in orthopedic fellowship. I was studying for my written board exam. Because you take it right after you graduate plastics residency. So some people don't take it and they start working, and so then they're studying while they're working. I was working as a fellow,
Right.
so I had to study. So I passed that, and that's when I became board eligible. So
Is
once
that
you graduated and you passed that, then you're board eligible.
Is that test, is it just pass or fail, or is it like a spectrum of
Yeah,
of a
I mean,
grade?
they give you your percentage and kind of like your percentile, like where you fall with your cohorts, but it's pass or fail. But so they have like a certain cutoff threshold
Is
based
that
off of who takes it.
so? In the world of doctors, is that percentile anything people ever utilize to position themselves
good
better?
question.
Like, I mean, like when we're in school, we're like,
Yeah.
oh, I got a 3.7. Oh, well, I got a
Yeah.
3.8.
Well, and
You
then they'll
both
give
had
you
A
a-
minus averages, but one
Yeah.
was a little better, right?
So yeah, this goes back to medical school. So residency training bases a lot of getting interviews and going to different hospitals and seeing if you can be a resident at that program based off of your exam scores in medical school. So there's a step exam, step 1, 2, 3. That's kind of like the medical school board exams, and that's to see how. And so that is huge. So my step 1, I did very well. I was like the 99th percentile. So that kind of opened up the opportunity because plastics is the most competitive residency to get into.
Right.
So it's dermatology. I think ENT is lower now. Orthopedics is very competitive, but plastics, and it may have changed in the last few years since I've been out training, but it's always in the top 3 because one, there's not a lot of spots in the country. There's maybe when I applied, there were 85 spots in the whole country for plastics residents, and there was 300 some applicants. Versus like internal medicine,
So
it's
that's
like 30,000
85
spots.
So that's 85 resident spots across all
The United
plastic
States.
programs in the U.S.
Yeah.
That-
85.
I guess like
Out of
when
all the medical schools.
when you were in your residency, I guess I just envisioned that you were like amongst like 12 other residents at the same time, and so that
Yeah.
like changes like that perspective. Like, were you literally the only resident, or how many other plastic surgeon residents did you work with during your residency?
Yeah, so I had There were in my year, there were two, me and one other person, Dr. Ford. So,
That's crazy. That makes it even more prestigious than we already thought it was.
well, it's just
To
so
you- to the outside
competitive
people,
to,
yeah.
to get in, you know, it's just, there's not spots. I mean, you don't have a spot, so I'm interviewing as many places as I can, you know, I think I went on like 13 interviews or something, and I try to do as many as I could, because you just don't know, you try to get in, you wanna be a plastic surgeon, and they're all accredited programs, you know, so you'll be able to be board certified and things, but, yeah, so you know, the step exam was huge, because that was kind of their threshold, they're like, well, you know, the score goes from, I don't know, like 185 up to like 270 or something, some weird numbers.
Mhm.
And so, you know, some places will say, well, the cutoff is 240. Like, if you're not above 240, we're not going to look at your application.
Right.
You know, so that's because they don't know, because the same thing. It's like there's so many good applicants. Like, I don't know, this guy's like an Olympic swimmer. This guy,
They
you
have
know,
to have some way to filter it down initially before
Yeah.
they start
exactly.
doing deeper dive analysis.
So that started early on. Then they got me into plastics residency training, and then from there, if you want to do a fellowship, fellowship's very competitive too. You know, like where I went, there was 2 spots, but again, same thing. There's not a lot across the country. Probably a little less competitive, but so for me, the problem is I applied for an orthopedic fellowship at USC, so it's an orthopedic department, hand upper extremity fellowship. They did a lot of plastics too. We did free flaps and
Mhm.
tissue stuff. That's why I liked that program and picked that as my number 1 to go to, because it's a match system too.
Right.
You know, so it's like I rank the places I liked, and then they rank who they liked, and then some weird computer algorithm and it matches us. So it's
Just
like, I
as
don't
a
get
side
it.
note, I know they do the same thing with med school, right?
Yep.
And when you had first told me about that, you going through it, like, I would love to get behind the scenes and see what that algorithm is doing, because that just sounds so bizarre for it to be
so
for it to be
med
the
school's
way people are
different.
chosen.
Well, okay, to get into med school is different. Med school is you could
Oh,
get
I
like
guess
5
not
offers.
med school, residency.
Yeah, residency, and then residency fellowship same.
Yeah.
Yes, yeah, exactly.
Right.
Yeah, no,
This
yeah,
match thing. So I rank
Yeah.
USC 1, Utah
Yep.
2,
Yep.
but Utah ranked me
Yeah.
7, and
Yep.
USC ranked me
But
3.
then the guy that they ranked 1, or the
Right.
girl, she ranked it 3. Yeah, I don't know how they plug it in. I don't get it.
Interesting.
It's voodoo. But it somehow works. So I end up going to my number 1 USC. But because it's orthopedic, most of the applicants when I was there were orthopedic residents.
No,
so
with
there's a
no intention of
ton
doing
more.
plastics, right?
Yeah, they don't do plastics. Yeah, they
Okay.
want to do hand upper extremity because they don't want to do the joints and stuff. So there's this crossover that we do.
Okay.
And so there's a ton more orthopedic residents in the country. Still competitive, but there's just way more. You know, it's like I think 75% or more of the applicants when I applied were like orthopedic residents.
For USC.
Yeah. Actually, yeah, most of the people that applied at USC were ortho. Yeah. So my co-fellow, she was ortho. or is
So,
ortho.
like, if you were to see another, if you're just at a dinner party with
Yeah.
a bunch of plastic surgeons, like I know there's conferences you attend with
Yeah.
plastic surgeons and stuff like that. Is that a question you might ever hear someone say, like, oh, what was your board score? Do you think that?
I think after that point, the board score doesn't matter. Now, the board score still matter for fellowship. It does not matter after that.
So, okay.
Yeah.
Okay. I
So
get what
I'm
you're
sorry, my step exam score that I took in med school mattered for fellowship too, the same as it did for residency.
Mm.
But after fellowship, and then once you're practicing, or either you're working at an academic hospital, you're working at a community hospital, you're working in private practice, those scores don't matter anymore. That doesn't matter.
They just look, you're board certified at
Then
some point.
that's
and
the
they're-
next, yeah.
That's all is
Yeah.
significant to them.
Yeah, and you still have to meet. So I'm going to get scored for my oral exams too. So I have to still meet the criteria to pass that, and they'll tell you my percentile, amongst the other applicants and things. But yeah, I have to be able to score well enough to do that. Now, they have my 5 cases that I have to know cold. What I've been doing now is actually after this I have to go study. So last night I had a study group. So there's like 7 or 8 other plastic surgeons across the country that we formed a study group,
Mm-hmm.
and we all Skype kind of together, and we go over what they call unknown cases. So there's a ton of cases, from head to toe, because plastic surgery is everything, right? Yeah, I do a lot of aesthetics here and hand, but there's a ton of cleft lip, cleft palate, abdominal wall hernias, chest wounds, head wounds, all these things that we do, cancer, all that stuff that's part of our training, and so I have to know all that stuff too, even though I don't do it every day, And so there's these unknown cases, and so we've been studying those together. We kind of go through and talk about these cases, and there's study resources. But that's a huge component of the boards too, that I don't even know what they're going to ask me. They'll throw up a picture there, and I have to tell them what
So
it is and what I would do.
are
to
you
treat
doing
it.
that to prepare for like the unpredictable of
Yeah.
what they're going to ask you?
Yeah, because I have no
Just
idea.
to like help keep your brain like on its toes of
Yeah,
being able to like
reminding.
think of something on the spot? Is that like the purpose of the study group?
Yeah, so like for example, last night we went through wounds, right? So we do a lot of wound treatment, like for example, a cardiothoracic surgeon, they may do like a bypass for a patient, because they had a heart attack or one of the arteries in the heart, the coronary arteries is like clogged, so they bypass it, right? So they have to go through the sternum to get there. They do it, they can break down, get infected. These wounds open up. You're staring at the heart, You have open wound, like what do we do? So they call a plastic surgeon. We would take muscle flaps, like say for the pectoralis muscles, place them in there, take a rectus muscle, take the omentum from the abdomen. There's different ways to treat it, but I have to be able to say, how would I treat this? What do I look for? What do I, if something happens, how do I do that? I have to know all that stuff. So we were doing that last night. We talked about sores on the behind, abdominal hernias. We treat all this stuff. So yeah, just going through it because I don't do that every day. I did a lot of residency training, but that's not my everyday thing.
So once the the oral boards come and you've done it and whatever the results are, like let's just say it is a pass, you do pass. Is there what do you think you're gonna feel like that? Is there gonna be like a huge sigh of relief? Is it gonna be like are you gonna immediately feel like you have less day-to-day worries because maybe you don't need to track your cases in as much detail? Like what do you envision
Yeah, that's
that?
a good question. So even right now, because I'm not, I collected my cases up until April, submitted them, right? There definitely was a little bit of like sigh of relief, like okay, like obviously I'm not having to scrutinize every case, but what I've been doing though is I every case I still treat it as if
Still like a
now,
minimum detail.
yeah,
you
no,
keep.
I still treat it as if I'm collecting for my boards because I figure out every patient deserves the same care for me, the best
Right.
care. So to me, the best care is to always think of okay, if I'm board certified or if I ever become board certified, how would I treat my patient? There's criteria that they were looking for. So I try to do that same thing for every patient. So I haven't changed that at all, and quite honestly, I had a patient the other day. I said, if I become board certified, like you said, it's not going to change my practice. I feel like I'm doing everything I can to be a safe surgeon. Obviously, like I always take criticism and try to learn. I'm constantly trying to learn and still learning, but like it's not going to change like
It just
how
provides
I
that
operate.
extra assurance for new clients that are coming
Yeah.
in. Like, hey, they come in, they get to know you. Some people come in because they think they know you from seeing you around, and they have that trust in you. But now they'll
Yeah.
also see, oh, he's also board
Yeah.
certified.
Yes.
I know he's gone to the highest levels of training and
Yeah.
approval that I can even trust him even more to operate on me.
Yeah. And that's why I want to do it. I worked with some surgeons in my training that are not board certified to this day. They chose not to. It's a voluntary thing. The American board does not make you do it. Now, certain hospitals, for me to be able to operate the hospitals, one of the criteria is that I have to be board certified or board eligible. So my board eligibility is only for 8 years. So at some point, let's say I'm like, oh, I just don't want to do this. Well, after my eligibility period runs out and I don't get board certified, well, then the hospital say, well, you're not board certified in your specialty, you can't operate. So I always want to maintain that because for my patients, like I tell them, and this is the one thing I tell patients to ask if they see other surgeons, whether it's a plastic surgeon or a non-plastic surgeon pretending to be a plastic surgeon.
Cosmetic surgeon.
Yeah, cosmetic surgeon, we'll talk about that in a minute. Ask that surgeon, this is very basic, just say, this surgery that you're going to do in your accredited facility, because we have an operating room here, right? It's quad ASF certified, meaning so we've gone through the accreditation process that we're here to make sure that it's safe for the patients. We're meeting criteria that they've established, and so me for the boards. I have to operate out of a accredited facility. I can't just go operate, in my garage.
Somebody's house.
Or even a office that has an OR but that's not accredited.
Right.
I can't operate there. Those cases would not have counted for me.
Right.
So. Yeah, so operating there, but ask the doctor. Okay, this is a very important question. It's very easy. Plastic surgeon, just say, okay, this breast augmentation that you want to do on me, is this surgery something you could do at a hospital locally? Will a hospital let you do this same surgery as a plastic surgeon in that hospital?
And then that tells you whether or not
That tells
it's a
you
board eligible surgery.
Yep, if they're actual plastic surgeon or if they are like an oral surgeon saying that they're a plastic
Right.
surgeon or cosmetic. Okay. Hospitals are very strict because they follow the ABMS. So ABMS is the Board of Medical Specialties kind of accrediting body to say, okay, there's 24 specialties. Let's say ophthalmologist, right? American Board of Ophthalmology. American Board of Pediatrics, American Board of Gynecology, American Board of Ear, Nose, Throat, American Board of Plastic Surgery, 24 recognized boards, okay? And those specialties are things. So the hospitals use those 24, and they say, okay, are you in one of these 24? Okay, if you are, then those surgeries under that board are ones that you can potentially do. So if I was an OBGYN, and I was in my office here, and I want to do a tummy tuck, I could do it because it's my office. I can do whatever I want in my office. But if I go to the hospital and I say, I want to do a tummy tuck on my patient, they'll say, are you a plastic surgeon? No. Gynecologists do not have privileges to do tummy tucks in a hospital. So that's why you can ask your surgeon, can you do a tummy tuck in your office as you could do at the hospital? If they know, they say, well, what are you then? Because they'll say, well, I'm a cosmetic surgeon. Cosmetic surgeon is not a real specialty. Cosmetic surgery, aesthetic surgery, is a small portion of what we train and do as plastic surgeons. Very small. Like I was saying, I have all these things we've been studying. If you look at their cosmetic surgery, although it's a pretty broad area, right, head to toe, is only a percentage of what we do as plastic surgeons.
That's good to know, the little tricks. Not that
Yeah.
I'll be needing, hopefully not.
Yeah.
And if I do, I think I know somebody that can help me, so.
Yeah. I mean, that's the important thing. I try to educate patients that, every patient doesn't have to come to me. When I see patients and they're not shopping around, but they want to get the feel for different plastic surgeons or different offices, or see if they kind of vibe, or they can, whatever it is, you kind of have to click. It's kind of like a dating game almost,
Right.
And so I realize, not every person's going to come to me. That's fine, and I don't want to operate on every person because they might be a good candidate, or I can't, in my hands, do what maybe they're looking for that maybe some other plastic surgeon can do, So I get that. But my thing for patients is, look, if you're going to go somewhere else, please make sure that they're an actual plastic surgeon, they're board eligible, board certified. So that's kind of that stamp of approval from the American board, say that they're at least considered safe, and they know, at least you think they know what they're doing,
So, I mean, like you pointed out, you try to take the patient's interest, as the priority, so like you'll recommend that they go, or, maybe not recommend, but you're willing to let them know that, hey, there might be someone else better for you, whatever the case may be. Do you ever have someone that comes in and almost wants you to convince them to get surgery? Like they want the surgery, but like they're torn, and they almost are like instigating you to
get them
to make them to commit, you know what I mean?
Not really. I've not seen that, but for me as a plastic surgeon, I used to do sales, like I told you in the last podcast. I worked in the mall growing up, and I did a lot of sales, and I was actually really good at it. Sold really well in retail. But as a plastic surgeon, that is not my role. I am the surgeon, I'm the physician. I'm here to advise someone on what I think is safe for them in terms of surgery. They'll come in and say, I think I want this. They don't know, and they want to convince. I'm not here to convince anybody. I'm not here to say, yeah, you need this. And I would never point out something to someone. If they came in for their breast, I would say, oh, you need a rhinoplasty. Your nose is terrible. I would never do that. I don't ever point out things that are irrelevant to what their concerns are. So I would never push anybody for surgery. And in code of ethics and things, that's American Board of Plastic Surgery, ASPS, American Society of Plastic Surgeons. These are all code of ethics things as well that I've read, try to memorize, and know things that we shouldn't do. I would never do that.
I think you've mentioned a couple of cases in the past where like you've actually had to turn people away because you didn't feel comfortable with either the request or the circumstances that the surgery would have required, right?
Yeah. So there's certain patients that, it's always to me about, are you a good candidate or a good fit for the surgery that you're seeking, right? And am I a good enough, not good enough surgeon, but am I the surgeon that can provide that for you? And so those are things that I'm always thinking of. That's what I'll talk to patients about. And yeah, I've had some patients where, not that the expectations are unreasonable, but that either I thought it was unsafe for them, or that the result that they were seeking was something that I couldn't provide them. Because I don't want to ever. That's the other thing too. For me, it's setting expectations up front with the patient. And I say that. I said, look, we're going to talk about your breast surgery today. We're going to talk about breast augmentation, what your desires are, and let's talk about expectations of surgery. What is it that you're looking for? Like how big of breasts are you looking for? How much of a cleavage are you wanting? These are all things I talk about. And if they want something that I can't deliver, I'll tell them, like, look, this is what I can do. This is what I think, based off of your anatomy, things we can accomplish. But if they want something else, then I'm not going to do it because I don't want to disappoint them. It's not, to me, it's not about money. It's not like I'm going to do all these cases to make money. I want to have patients who are happy, who I've established relationships with them, and it's for years. You know, and my breast augmentation patients, like I'll see them every year as long as they have implants in, because I want to check on them. So, you know, once you become my patient, you're my kind of part of the family. You know, so I'm kind of
You're
selective.
invested in their long-term health at
Yeah,
that
like
point.
so I'm selective in who I operate on too. I think that's one of the and someone had told me this before, but one of the hardest things I think to do as a surgeon is to know when to not operate on someone, because you can you can just operate everybody, you know. I mean, you can go down like, oh yeah, you need surgery, you need surgery, you need surgery. It might not be the right thing for them. It might not be the right time for them. You know, some patients come in and you know, like they want a tummy tuck, and I say, look, you're really close to, you know, your weight. Like if you just lost a few more pounds, I think your outcome would be spectacular.
Right.
I think you'd be much happier, get your money's worth, you know. But that's something I can't do for the patient, you know. And so, like, yeah, I could operate on you right now. I just don't think you're going to be as happy if you lost like 10 pounds, you know, because sometimes you have intra-abdominal fat things. I think you'd have a nicer contour. I think we'll be able to get more tissue off. You know, there's different reasons why. And so, and I've done that. I said, let's wait. And you know, because again, like they come in, they may end up going somewhere else, and so I may do it. That's up to them. But I want them to have a really good result, be happy.
I know I've seen a couple where like it seemed like they wanted multiple things done at once, but because of circumstances, you did one thing first, and then 6 to 9 months later, you did the second procedure that they initially wanted done. And
Yeah.
it seems like that, even though you have a longer period of overall recovery time, right? But it's a safer way to go in that situation.
Yeah,
right?
and I tell patients it's all about safety. You know, like I saw some consults yesterday in my clinic. You know, one person, wants a lot of stuff done, and I said, look, this is what I think I can reasonably do in 6 hours or less. So 6 hours is kind of the cutoff that we use in an outpatient or an ambulatory surgery center, right? Not in a hospital, of surgical time. You know, over that, then it starts to be a long case, a lot of anesthesia. Patients have a hard time waking up. They should probably be admitted overnight if they don't wake up enough and things. And, you know, it could be more dangerous. So
Right.
try to stick to 600. So that's what I do. I say, look, we can do this safely. Or sometimes it's like, look, I can't safely put implants and lift your breast at the same time, whether it's because of the size of your areolas or the size of the implants you want. There's a lot of reasons. So I say I'm going to stage it. So I do some staging too. Like I'll break surgeries up 3 months, 6 months. Or some patients have something done, like a tummy, like, you know what, I want my breast done now. So they'll come back 6 months later. So there's different reasons. But yeah, definitely. I think it's safer. And you know, you mentioned maybe more recovery time. And I do talk about patients like, look, yeah, I mean, ideally, if you did everything in one surgery, you'd have one recovery period. But that period of recovery
Be harder.
may be harder than if we broke it up. And I've done that. So, you know, especially some patients who are a little bit older, like I've broken up breast reductions with a tummy tuck. And they did great from each, you know, like the breast, like a couple days, and they were sore. Tummy, 1 or 2 days, you know.
It's like a maximum level of tolerance our bodies can handle of
exactly.
pain or fatigue or soreness.
And I take into account, like I said, age. What other health problems do they have? And so there's all these things that go into it. You know, I don't just like make up stuff. At least in my mind, I don't make it up. I try to do it based off of, you know, like scientific research in the plastics community and, you know, studies that have said, oh, well, you know, if your BMI is a certain level, well, some studies have shown that you're high risk for infection or wound breakdown or fluid collections or, you know, whatever it is. And so those are things I try to use and say, look, you know, I think we should adhere to that for your safety.
You had one tummy tuck that you showed the other day on Instagram was 9 months post-op.
Yeah.
And like that one was incredible because like had I seen the you know the after picture 9 months later, or I've seen them in person, you would have never thought anything that they had, because especially if you've seen the before, like the before, it was a significant change, and I don't know if how much, if any, exercise happened over that 9 months, but like it looked like a gym toned stomach.
It's amazing.
And I was like, wow, that was one of the more impressive ones I've seen, because some of the ones I see are, it seems so minor. I'm like, oh, why, you know, why did you? I'm curious as to what their reasoning to get it at that point, because it doesn't seem significant. But this one was a huge change, and I was like, that's crazy.
Yeah, I've noticed. So I really like tummy tuck surgery. You know, I mean, it has a little bit higher, it does have a little bit higher risk of blood clots and DVT. So I always, again, for safety reasons, screen for that. We'll treat patients to prevent those things from happening. But I call it the gift that keeps on giving, because tummy tucks, you know, combined with some liposuction, like over time, to me, they look better and better, you know. And like you said, you see them, they look more toned. And I don't know, and I think some patients get more motivated too. And there was one I posted a few weeks ago, you know, it's like one of the first surgeries I did here. You know, she's over a year out now. and you look at her before and after, you're like, that's not the same person. You're like, it is not the same person. But she just got so fit after, so motivated after having the tummy tuck and breasts and stuff. It's so awesome.
Well, it's like, you pay a lot of money to, get these results from you, and you don't want to let it slip right back to where it was, right? Because the motivation is there partly because you spend a lot of money, but partly too you love how you look now, and so it's like, oh, I got to keep this because I just love how I feel, when I look in the mirror. So, so next week you're going on a trip, and it just reminded me that I think it was when you were in med school, and maybe when you were it was either med school or end of school when you're trying to figure out what medical school you were going to. I can't remember what it was, but you went to Harvard for like a week or two, right? Something like
I went there for
days,
4 weeks. So okay,
4 weeks, even more.
Yeah, I was in medical school, and so as part of kind of interviewing, getting ready for plastic surgery residency interviews to get into match for residency, people do what's called away rotations. So I would actually left here for 4 weeks and went and stayed with one of my friends who was a general surgery resident at Mass General Hospital. So yeah, Harvard, they have like Mass General, Brigham Women's, Beth Israel, and there's a children's hospital, whatever. So they have a ton of hospitals all under the Harvard kind of system. But MGH is one of them, and so I stayed with my friend there for a month, and it was kind of an audition. It's like an audition for a month. I'd get up like 3:30 every morning, go get numbers, get everything ready, and just like you always have to be at your A game for 4 weeks. It's hard,
So
but it was a great experience. I always wanted to go back east and just to see like what East Coast kind of vibe was versus here. And that's why I went out there and had that friend. So it was cool.
So I brought that up because the trip you're going on is to Stanford.
Oh yeah.
And that's like the Harvard of the West, right? And so like it just from a step back perspective, like to me that's just so cool that you get to go partake in these historic institutions and add it to your list of accomplishments and so forth. And so like talk to us about what are you going to be doing at Stanford?
Yeah, so I'm going to Stanford. It's actually an oral boards like review course. So I paid for this thing, so that's why I'm going there. They'll take your money, I guess, to go to Stanford. But I'm going there, and actually all the people in my study group, all these plastic surgeons across the country, they're all going as well. So we're all going to be there at the same time. But essentially, I'm going to sit for a week straight and go through all these unknown cases, go through my cases. They're going to kind of ask me and kind of help prepare me for my oral boards, because I do not have time. Like I'm trying to run a private practice. We're doing this podcast. I do Instagram, like I told you, it's like a part-time job, and I have a family. I have 3 kids. You do too, and so I don't have time. So like I sit down to study with this group. It's like 1-2 hours. Like I don't even know, and then I have my church duties. So there's so much. And so I just need a week to dedicate. I have to build it in.
Specifically build it out, otherwise you can't get it.
So I did that for medical school, and this is why I kind of thought I wanted to do this, because some people are like, it's not worth it. To me, it's worth it because when I was in medical school, getting ready for my first step 1 exam, like at the time I didn't know I wanted to do plastic surgery, because again, I mentioned in the last podcast I thought I wanted to do cardiothoracic, but as I was studying with my friends, they were like so dedicated, and I had no aspirations like, oh, I want to get the highest score or anything. I wanted to do well, but I didn't know really what I wanted to do. So my whole goal was, I'm going to do as well as I can, and then, decide from there. Do my 3rd year, all my rotations, and see what specialty I like. If it's psychiatry, great. If it's family medicine, great. I just want to do well on the exam. But we went down to St. George for like a week, me and a few of my friends that we studied together, and we literally studied like 12 hours a day, 14 hours a day. Just study. I memorized a book of like 400 pages, literally memorized it. It helped me a lot because, between that and studying everything, I was able to kind of put it together. And so I did really well on my step 1 exam. And it kind of opened my eyes like, oh, like even things like I never even considered plastic surgery or dermatology, like I have an opportunity. Like at least like look at it, and if I'm interested, I have a chance, like it's not guaranteed at all, but at least my foot can be in the door. And so I kind of, for the boards, I thought, I would like to just dedicate that week. And
I mean, if like you said, you've been planning for this moment, so to speak, for the last 8 years. You've spent, even longer in post-high school schooling, and it's like it would be silly not to spend 1 week just to give yourself that much more of a chance to make this success on the first try. Yeah,
and again, at the end of the day, it's voluntary, but I want to do this for my patients, to say like, look, I'm trying
Give
to
them more
become.
comfort.
Yeah, like exactly. Again, I don't think it's gonna change what I do. What because I feel I had great training in Loma Linda. We literally did like all aspects of plastic surgery, which was awesome. And then just add on top of that my hand specialty training. So I feel like I was very well trained, and I feel like I retained a lot of that, and I have a lot of the techniques and principles. And that's what I wanted to mention at the beginning. Plastic surgery is not a specific organ system. It is a principle-based specialty because it's more of, I gained all the tools in my tool belt to be a plastic surgeon, and then it's figuring out what tool to use or how to use a tool or make a new tool to do that surgery. So like I said, today I did a case I've never done before, but I had the tools in my tool belt. I had done many similar surgeries differently, but today I came across a problem, and that's why I love plastic surgery. It's a problem-solving specialty.
There wasn't a book to tell you how to do
There was
it. You
no
just had
book
to
to
use
tell
your
me.
skills to
Yeah,
figure out the best
and
way
come
to
up
do it.
with something new even. So that's
There's
what I
a-
love about the
Funny Seinfeld.
innovation.
Like I know you love Seinfeld,
Yeah.
and he did this one of these jokes a long time ago where he's like, you go into a doctor's office and he like looks and he's like, okay, I'll be right back, and he goes into his office and he gets out of it. He's like,
Yeah.
oh, what the hell was
He's
that?
like Googling.
And he's like,
Yeah.
oh, I've never seen that before. Like,
Yeah, that's before Google. They would have Googled it now.
Yeah.
I will knock on wood. I mean, I've never had to Google anything in surgery. Now I've been in surgeons, other surgeons who had Googled, but I try to go into every case prepared. But you never know what you're gonna run into. Even today, like I said, you run into things, and so it's like, okay, take a step back. What are the principles that I know about what I'm doing? Anatomy is very important. You have to know where you're at all times. Even in the hand, like when I'm operating on the finger, for example, on the hand, I always am thinking, okay, there are the flexor tendons right here. There's the palmaris, the upper neurosis here. There's the median nerve down here, branches here. There's the arterial blood vessels here. There's the lumbricals. Like I'm constantly in my mind just going through the anatomy as I'm doing things because 1 millimeter off, you're gonna either kill the hand or paralyze the hand.
And it's crazy seeing those hand videos because like I hear you specifically calling out all those little pieces of the hand, and to me,
It
a
looks the same.
layman, I'm like, there's just a bunch of muscle and like, and then all of a sudden you grab the tendon and start making the hands move or whatever. I'm like, okay, that makes sense. I wouldn't have known that's what that was, like it, looks like a piece
Yeah.
of just fatty tissue or something, so it's crazy that, it puts in a new light of respect for like the knowledge you have of those intricate things. Like it's just on another level.
I think that's what I loved. That's what drew me to it because there was just so much. Like I felt like something I could never get bored of. Like even let alone hand surgery, but even breast surgery or anything like. It is different every time. Like today, like I said, it was totally different, and so I just love that I would never be bored of what I do.
So one of the interesting thing, like you talk frequently about this difference between cosmetic and plastic, and
Yeah.
and the stereotype is you hear plastic surgery, you think fake boobs, breast augmentation, and it makes me wonder though if plastic surgery, knowing now plastic surgery is so much more than that. How did that name evolve to that? Like, why is there not something more, I guess, encompassing?
Yeah.
Because you hear plastic, you think plastic, implants, right?
Yeah.
Or silicone like the name plastic and implants just seems to go so good, which is why I think people have that
Associate it,
connection. But do you know like how that name, like why
So
that name evolved to that?
the word plastic is that it's Greek plastikos to mold or to shape. So that's where this all started. You go back to like India, Shishrita, there's these documents, where they talked about nasal reconstruction, people getting their nose, some people were lepers, their noses would fall off, or even like in Italy, like in the 15, the Renaissance and that time period, these guys would run around cutting noses off. They had their ears and they would cut their nose off. So that's when all of plastic surgery, plasticos to mold and to shape the body was kind of started. So that's where that term plastics came from. And then, the specialty, technically it's like plastic and reconstructive surgery, not just plastic surgery, so reconstructive. And a lot of it was initially based to reconstructive only, right? So all these early things are reconstructing the nose. There is a cosmetic or aesthetic component to that, right? To have a nose in the center of your face, to not have a hole, to be able to breathe, to be functional, so all these things, right? But, and that's how it kind of evolved. And I think, and if you kind of add in there, okay, now you're talking about breast implants. So, actually in Germany, this guy named Zerny, Czerny, he's one of the first kind of guys to do breast augmentation. He actually took a fatty tumor, like a lipoma type of thing, from this lady's hip and put it into her breast to give her more breast volume because she has some breast asymmetry for whatever reason. And that was like the first breast augmentation. And then you come to Dow Corning, and then the creation of silicone breast implants, the first generation. This now you're going like in the 50s. Okay, so that's kind of the first ones, and kind of like the iPhone, or iPhone 11 Pro Max, whatever. Now, we're up to like the 5th generation implants over the last several decades, and implants, I think, just because it became so well known and well kind of in
it's
the
most
media
obvious
and
one, right?
obvious.
Like somebody walks
Yeah.
in with new implants, and like
It can be. Yeah,
it
some people
doesn't
don't,
matter
but-
what they're wearing. Like, okay, that person has implants, right? So I think it's just
So
more
maybe it's-
obvious,
Yeah.
and so then like
And
you may not know someone had nose surgery,
Yeah.
you may not know somebody had something done to their hand.
Yeah.
So maybe it was just like an obvious surgery that then, plastic surgeon's done that. Oh, okay, plastic,
Yeah, and I
implants,
think a lot of it is media driven. If you think again around the 50s, this again after World War II. So hand surgery started World War II. If you kind of look at timelines,
Mhm.
because the Army is like there's 7 U.S. Naval Army hospitals kind of set up between orthopedic, plastics, and general surgeons, kind of treating these war wounds from war veterans from World War II. So that's when hand started. But then you go into the 50s again when implants were coming around. And you think of how culture changed in the United States, in terms of, people actually wearing swimsuits and the bikini that was invented, this like French guy in America. And so now we're in bikinis. Well, now in a bikini, breasts, like you said,
More
are maybe
prominent.
more prominent. And so, I think it's a cultural thing as well. And then because it's cosmetic and it's cash, there's this aspect to it that's financial that I think other specialties started to see and say like, hey, I want to do that.
Right.
Why am I here billing insurance for this, getting paid $12 for this case, or for seeing a patient? Well, I could actually do a surgery, even though I'm not a surgeon, whatever, but I could do this, get cash for it out of my office, and so that's where this whole cosmetic thing, I think, kind of started and brewed, is like, well, okay, I'm not a plastic surgeon, I can't call myself that, but there is a cosmetic thing to it, right? So I can call myself a cosmetic surgeon, and that's where there's like cosmetic boards and things. Those are not, again, ABMS certified board.
Right.
Anything the word cosmetic in it is not. Now we, as a plastic surgeon, we typically use the word aesthetic. So aesthetic to me is kind of more encompassing than
Right.
cosmetic, or a little different term. So typically you hear me say like aesthetic,
Yeah, I know. I always find myself being defensive if I'm like talking about you to like family or
Mhm.
friends, and I'm saying, oh, you're a plastic surgeon. I'm always hesitant to use that word because I know what the stereotype is of what they think plastic
Yeah.
is, and like to me it's like, no, I don't want. I want to make sure you get your full credit because what you do is way beyond a cosmetic surgeon, and so I just find it's interesting that it makes sense the origin of the word plastic
Yeah.
in that environment, and like how it just happened to perfectly
Yeah.
align with that stereotype is, I
Yeah.
guess, unfortunate, because I think you guys who are real plastic surgeons deserve much more credit than what the layman might think a plastic surgeon is.
Yeah, and to me, at the end of the day, even if a plastic surgeon and all they do is breast augmentation, that's fine. But they have the
The
reconstructive
skills.
knowledge and skills if something were to go wrong. And that's what I tell patients is, look, I don't care, like, you can think whatever you want as a plastic surgeon, but I want you to know that I have the training so that if you had a problem, if you had a hematoma, if you had an infection, if you had, implant drops, this is asymmetric, I know how to correct it, or at least, I have colleagues and I have the knowledge and the resources to be able to do that. I'm not just going to ship you off to the emergency room and say, go see a plastic surgeon, because for one, they can't see you there. So I also tell patients, look, if you have a complication, can your surgeon treat you at the hospital? Can he say, he or she, meet me at the ER, I'm going to admit you, and we're going to have to take you to the operating room and then keep you in the hospital? No, because they won't have privileges to do that for a non-plastic surgeon.
What would happen in that scenario?
I've done it before. They call me when I'm on call. I'm the plastic
okay.
surgeon on call. They say, hey, we have so
they may
patient.
have another doctor, but they have to go to the hospital.
Yeah.
Their doctor can't operate.
Their doctor cannot.
They call whoever's on
Yep.
call
Yeah.
to come
So
work
now
on that
I am
patient.
dealing with another non-plastic surgeon who did a aesthetic procedure on a patient's complication. I can treat that, and I've done that, and help patients. But it's in the medical community, that's not very collegial. If you don't have privilege to do what you're trying to do, then, if you can't fully care for your patient, why are you doing it? I'm not going to go do open heart surgery on my patient. I've done it in training. I'm not going to go do it on my patient.
Well, and
I'm not going to brain surgery. I'm not going to go take out someone's gallbladder. I've done 50, 60, 70 of them.
it made me think of, I was thinking about this earlier. If you weren't doing plastics or hand, and I'm not saying you would necessarily be qualified for, but what would be another field that you are most closely qualified to do, like whether that meant you had to go do additional training, but like what could you pick up and go do outside of plastics or hand if you had to, and even if that involved additional training, like what are you the closest aligned to outside of plastics and hand that you?
Yeah, I mean for me, because there's one point in plastics training where it was so intense, I was like, I want to do something else. It was in my mind. I talked to Mindy about it. I never was serious, but I remember thinking, like, if this didn't work out for me, what would I do? I actually thought about that. And I think it's kind of more a personality thing, because there are some components of my training that, align with orthopedic surgery. Orthopedics or, vascular surgery, because there's a lot of there's crossover there. ENT, there's crossover when we do head and neck cancer, facial trauma, all these things. So there are some crossover areas in these specialties, which, I guess that would be the easy way to say, well, I could, orthopedics, I think, would align. There's a lot of things there that I like, and, even neurosurgery, there's some components to it. I think at the end of the day, if I were to shift or not be able to do plastics, I'd probably but I would probably shift my focus away from even surgery. If I couldn't do plastic surgery, I would not do surgery. I think I would do something else, because I'd be too sad that I couldn't do it.
Would it be like a general, like a family practitioner type situation?
I probably wouldn't be very good at that. I don't know, actually. I haven't thought about that.
I think you definitely have the personality for it, like, because I think, like, I think of family doctors, and like, to me that's, all in some sense they're supposed to be part of your family, right? Like, you have to feel like you can talk to them like that closely, and I think you, at least personality wise, you could do that, whether you wanted
them.
to.
It's a lot of knowledge. Yeah, and that's a lot of knowledge for them too, and definitely a lot of learning for me. I think it'd be fun to do on some level. I don't know if I'd be good at it, but maybe personality.
Maybe they could be, they got that show Wife Swap. We could do Surgeon Swap. No, I'm just joking. That's not a good idea. So, going back to the boards, you had mentioned there's this 8-year eligible period you have, and some people choose not to do their orals or anything like that. Let's say I chose not to do my orals and my 8 years expire. Do I no longer have the ability to become board certified, or is there just a different process I need to kind of go through to do that? Do you know?
Yeah, and I don't know the exact details, so I don't want to quote anything that I misrepresent what the board does, but I do know that there are ways I think you potentially extend it if you had to, but you'd have to write letters, you have to have reasoning as to why.
It's a difficult process.
Yeah, it's not just like, resign my renew
your
driver's license type of thing.
I can't imagine why you would just go 8 years and not have a need to, and then, or a desire to, and then all of a sudden I want to do that. It almost feels like you would have to just start from scratch in some sense.
Well, and I think that's part of why, if you're to that point, and probably some people are like, I don't do it, But it's like anything. I think if you're dedicated and there's something you want to do because it's for either your patients or for whatever reason, you may just have to suck it up and do it. But there are ways. I don't know the details and the nuances, but there's things.
I won't quote you on that, so.
Thanks. Yeah, I don't want to misrepresent.
All right. So, anything else you want to capture in this episode?
No, you had great questions. I think, and these are questions that I get from patients or family members or laypersons or whoever it is. I like talking about it because I'm going through the process right now, and I'm very open about it. I'm not. I would never deceive my patient and be like, I'm board certified. I'm not, so I wouldn't lie to them. But I tell them, look, I'm going through the process. It's a process. It's like you said, anything like this kind of driver's license. It's a very extensive process that I'm committed to do. And I tell if you want to go to someone who has the stamp already, and that they have it, that's great. I'm fine with that. I can recommend people to you that I trust, that are local or whatever. But most patients understand and see that, okay, I'm going through it. I'm committed to it. I'm board eligible, and so
One last question, I guess, on this is, so you did 15 years of post-high school schoolwork between college, med school, residency, fellowship. And then the last 8 have been all geared towards this moment of being board certified. Was there a moment somewhere in there that was kind of like there's no turning back? Like you had to just commit, like okay, like if I go any further and I decide not to do that, like I'm SOL, like, or I'm put myself in a horrible position. Like I know in the last podcast you did mention like halfway through residency or med school, I can't remember which one it was. It must have been med school, I think.
Med school, yeah.
That you kind of had this come to Jesus moment, so to speak, of changing, but like even for the long term of being board certified, because I imagine you would have wanted to be board certified even if you'd done a different field besides plastics, right?
Yeah.
So like,
and every board's a little different how they do it in their specialty.
So like, was there that kind of pivotal moment, like, okay, like I know I'm committed from this point on, like there's no other way I can go from here. That like almost puts more pressure on you.
I like that question.
Point.
Yeah. So to me, that moment was quite honestly when I was in training, in plastics training.
In your residency?
Yeah, in residency. So I was in plastics training, and I think the moment I kind of realized, like, okay, like this is the moment. It's probably halfway through my intern year, you know, because in my intern year I did a lot of rotations that were like non-plastic surgery.
Just for us that don't know, would that be your first year of residency?
Yeah. So intern year, at least in plastic surgery, is and a lot of general surgery and stuff. Intern year is your first year of training. So I did 6 years of what's called integrated plastics residency training. Integrated means that all of my training was in one program. You know, there's other ways you can become a plastic surgeon. You can do a general surgery residency, which is 5 or 6 years, and then do what's called a fellowship, kind of like I did, but a plastics fellowship for 3 years. So then you have to do 8 years of training after med school. So general surgery and then that. Or you can go the integrated route, so it's 6 years. So it's condensed. So I didn't do all the general surgery stuff, but I did do general surgery, but it was condensed. So like I said, my second year was very heavy general surgery, intensive care ICU stuff, vascular surgery, you know, neurosurgery, orthopedic, all that. I did all that, so I can kind of work with all the specialties, see how they do things. And then second, kind of end of second year, third year is when I started plastics. So after intern year, and then that's probably when I realized, okay, like this is what I'm really gonna do. Like I'm committed. Like I'm not turning back. I had no intention at that point, but I kind of realized, like, yeah, like this is what I'm gonna do, and if I have to do something else, like I'm gonna have to totally shift. So that's kind of like.
That's just, I mean, there's one part that's like so admirable about that, and then the other part just is crazy. Like it's like, you know, because I think about like even my college experience. I went to college with, I was so sure I was gonna do computer engineering. You know, I wanted to code.
Yeah.
And then I had a change of heart, not because of the coding aspect, because of other requirements to do coding. Ultimately, I ended up changing majors like 4 times, and we're just talking about an undergraduate degree, right? And so, like, you know, I try to put that in perspective of what you're doing. Like, I couldn't imagine that there was that many opportunities for you to change that many times, because it is such a long-term goal to like get to this point of being potentially board certified, becoming board eligible, that you had to just commit at such an early stage. And you know, that's, even though you were in residency at that time, and that's a little more than halfway, it's still like having that long-term goal in your head, like as your focus, like that seems like that would be a weight on your shoulders.
Yeah, and I think initially, you know, because I'm just trying to survive. Intern year, first year, you're just like, I don't know what's happening. I don't even know what potassium is, you know? I mean, what it is, but like, how do I check someone's potassium level? I'll never forget the first day of residency, intern year. I show up on the 8th floor surgical unit in Loma Linda Hospital, and I walk in. I'm wearing like my white coat. I'm just like, you know, no idea. It's like July 1st. I walk in. This nurse comes up to me. She says, "Doctor, your patient's, you know, phosphate levels are low, hypophosphatemia. What do you want to do?" And I'm all, huh? I remember thinking to myself, do we like treat that, you know? And so I said, "Nurse, what would you do in this, or what do you typically do in this situation?" She's like, "Well, we would typically order this amount of phosphate." I'm like, "Sweet, let's do it."
Have you seen Catch Me If You Can with
Oh
Leonardo?
yeah,
right?
yeah.
That episode where he's trying to be a doctor. He's like, what would you do? And he like said, he's like, And do you concur?
Concur. I concur. Yes, you concur. Do you concur? That's
That's
kind of what
I
it was.
envisioned.
Yeah.
That's what I imagined.
But I
happening.
learned early on, like, trust nurse. I mean, obviously, I have to make medical decisions as the physician, but like nurses play a very critical role and do a lot of it. So and have good advice. And so I think that's part of being a physician too. Is yeah, like you have to at the end of the year, you're kind of the one that's gonna take the blame for stuff, take the fall, or be responsible. But you have a team that can help you, and so that's what I learned. Like the first minute, I was like, man, this nurse is awesome.
Well, I feel like that was really good.
Yeah, man.
Episode,
Thanks for the interview, for asking me questions. It was fun. I like to talk about this stuff, because it's something that, like I said, I've gone through for many years and still going through and trying to figure things out. But it's interesting to look back and just see from like day one, didn't know what phosphate was, to now doing surgery and stuff like that.
And what's
on my
funny
own.
is you could have had all of your friends, me included, fooled because you were like, oh yeah, Jerry's in residency, like he knows everything, like he's a real doctor. Even though we knew you weren't, but like
Yeah.
we couldn't from the outside picture that you were going through that type of scenario because we're just
Oh,
like,
man.
oh, I
Yeah,
mean, he's
it's-
gone through 8 years of school already, like he's got to know like a lot already.
Yeah, I wish.
So that's I guess it's humbling to know that even you who, you're so educated and you're so skilled that even you had some point of vulnerability to like not feel like, you didn't feel completely in control of the situation. So I think it's refreshing to see that, you had to acquire all these skills the same way anybody
yeah.
would acquire any other job set skills.
Totally. And I think that's something like always, in my mind at least, is always something that I think about is like, I don't know everything, and that's the concern I have is some surgeons, and probably more in other specialties, but have almost like this complex that they know everything, and maybe they do know everything in their field, but I can tell you right now, the more I do in plastics, the more I realize like, oh my gosh, there's so much I don't know, and there's so much innovation going on all the time that it's just a constantly evolving thing, and so I think to be able to accept that and say, look, like I don't know everything, and I'm willing to ask other people for help, or people who may know more about something than me. I think to me, that's part of being a good physician and surgeon in my mind is knowing when to ask for help. Don't think you can do it all by yourself.
Agreed. All right, well, I'll let you
Cool.
Sign off like you normally
All right.
do.
Well, thank you, Ron. Again, this is Chit Chat with Chiddy, MD. I am Dr. Terry Tidler, Jerry Chidester. Really, thank you guys for watching this episode. If you're able to stomach all the way through it, hope that you enjoyed it. Hope you got some stuff out of it. Please comment below. Ask some questions. You can DM me on Instagram or through Chit Chat with Chiddy on Instagram. That's our other account. So Chidester MD or Chit Chat with Chiddy MD. I'm more than happy to answer any questions. Happy to do lives. Happy to do. I do actually live events here all the time. So keep an eye out for those. We do Q&As all the time, trying to educate patients and population here. I do go sometimes on KSL and try to educate and talk about safety in hand, whether it's snowblower injuries, gardening tool injuries, ATVs, fireworks, these types of things. I try to, give you tips and things on how to keep yourself safe. So stay tuned for next week's episode. I don't know what it's going to be yet, but we're working. We have several guests.
We like cutting it close and deciding at the last minute what we're doing.
Yeah, because I'm going out of town this weekend. So this is going to air.
We're both going to be out of town. So.
Yeah, you're going downtown too. But again, thank you guys so much for watching. Again, don't forget to subscribe if it's on YouTube. Click the bell to get the notifications. It really would help us as well. You can check us on iTunes under Chit Chat with Chiddy, as well as Spotify and Anchor FM, as well as on Google. If you're on an Android phone, you can go to Google Podcast and check us out there. All right, we'll see you guys next week.
Well, thanks.
Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat with Chidester. MD. Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat with Chidester. MD. Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat, chit chat with Chiddy. Chit chat with Chidester. MD. Chit chat, chit chat with Chiddy.
Ooh, these are my favorite too.
That cupcake.
Mindy make these?
I don't know. No, it was one of our medical assistants. Stephanie is her birthday. Oh, she made them and brought them in, or someone made them for her? I don't know.
Rainbow chip and
Love it.
funfetti cupcakes are my absolute favorite.
Totally. Well,
I don't even eat cupcakes or
do you-
cake, but when I get this, I eat.
Do you remember when it was off the market for like several years? I didn't realize. I tried to go on eBay, dude. It was like $300 to get like one container.
of the frosting, right?
Frosting.
Yeah.
Yeah, because you can get.
I
the
think
buffet
Mindy is
cake.
the one who told me that, oh, they're back, and I'm like, what? And I went there and I like bought 2
Yeah,
of them.
because Katy Perry. Well, a big thing I saw online a couple few years was Katy Perry made a big deal about it, and then Betty Crocker. I think Betty Crocker came out and, or was it Pillsbury?
Betty Crocker.
Betty Crocker. And they came out and said, "Oh, actually, we're bringing it back." Or
Yeah, they had the cake the entire time, but then they
Yeah,
tried
they
to
were
rip us off and say, oh, here's these here's these sprinkles you can put on it. It's just the same. Like, no, those are hard.
Yeah.
And these rainbow chips are nice and soft, and like,
yeah.
like, come on, don't
I
try to take
think
me.
Someone said I think it's like white chocolate.
That would make sense.
fondant
White
or
chocolate,
white
and
chocolate
then
that's
they
colored.
Yeah,
Yeah,
that was
'cause
colored.
it has that kind of a little piece of chewy chocolate.
Yep.
Soft.